Yeah. Okay. Well, I'd like to welcome you all to the first AFMW Open Forum event of this year of 2022, in which we talk about COVID-19 and moving forward in 2022 after a harrowing 2 years, and we're entering our third year. I'd like to welcome all of you who are attending, and I'd like to also acknowledge the traditional custodians of the land from which we all speak and where we all reside, and acknowledge their elders past, present and emerging. I'm in Victoria. I'm from the Wurundjeri, on Wurundjeri land, from the Kulin people of the Kulin Nation. And I know that Marjorie has entered where she's from, and we're from around Australia, as AFMW is made up of a diverse number of diverse women who are from all backgrounds and also from all parts of Australia. And they'll be zooming in on this throughout, and some will actually opt to listen to the recording. So this is being recorded. I'm going to introduce our speakers tonight. Margie Danshan, Associate Professor Margie Danshan. I'm really, really honoured that Margie has agreed to speak tonight and to talk to us about paediatric immunisations, and also Charlotte Hespy, who is ACT New South Wales RACGP Faculty Chair, and also on the board of RACGP, who will be talking to us about her experience in New South Wales and what it's been like rolling out the vaccination programs in New South Wales during this overwhelming Omicron outbreak. And Charlotte, I can assure you, has not rested throughout the entire time and has been really vocal about the pit holes in the program, and as you have, Margie, been supporting government in informing them of the needs in primary care and in the community. So without I will just introduce you, Margie, and your group leader of the vaccine uptake, Murdoch Children's Research Institute. If you could just give us a little rundown of yourself.
Yeah, sure. Yeah. And keep it super short. Yeah. So hi, everyone, and thanks so much, Magda, for the invitation to be with you all tonight. I am a paediatrician at the Children's in Melbourne, and I too would also like to acknowledge the Wurundjeri people of the Kulin Nation and pay my respects to elders past and present and emerging. So I'm a paediatrician, and I'm also a vaccine researcher at the Murdoch Children's Research Institute and the University of Melbourne. And I have been working very closely with the Victorian government on the COVID rollout since the start of last year. And then I actually was seconded to the Department of Health for the last 3 months of last year, and I'm continuing to work closely with them. And I've also been sitting on one of the ATAGI working groups on vaccine safety, confidence and evaluation, and working closely with the Commonwealth Government. So just very much all around the vaccine program and trying to look at strategies to improve uptake. But one of my roles towards the end of last year was actually to work on the primary school aged rollout for Victoria. So I'll share my screen now and just run through a few slides. And, you know, there are probably a few too many here, but we can just skip over them. And please feel free, if you have a question or there's something that I raise that you'd like to know a bit more about, then just stop me as we go through. So really, with the primary school age rollout, I mean, we've seen the rollout progressing from older Australians initially in the priority groups and at-risk adults, and then down to young people, teenagers, and now the primary kids. And this is a really challenging age group to vaccinate because it is quite complex, the reasons why we are choosing to vaccinate children in Australia, especially as we've seen other countries making very different decisions. The UK are only vaccinating high-risk children in this age group, and Denmark and Sweden have chosen not to vaccinate primary kids at all, and Australia has chosen to vaccinate all children. So it is very tricky, and I think that'll probably become clear as I go through some of this information, just why it is so difficult. The main reason is that COVID infection in children is predominantly a mild illness, and at least 1 in 5 children are completely asymptomatic when they are infected. And, you know, the vast majority of children just experience COVID like any other viral respiratory illness, particularly runny nose, cough, fever, aches, chills, and a very small proportion need admission to hospital. In the recent New South Wales data that came out in the last couple of weeks as a preprint, they reported on a 4-month period from June to October last year with the Delta variant, and 1.3% of positive children needed admission to hospital. But in the most part, as paediatricians, we would not consider those children that sick. They were admitted to hospital for 1 to 2 days. Most of them were either under 6 months or they were teenagers who were unvaccinated with medical risk factors, particularly things like obesity or diabetes. The 5 to 11-year-old age group are the age group with the lowest risk of severe disease. Most of these kids were admitted for 1 day, maybe 2 days, and over 93% didn't need oxygen. So, you know, yes, severe disease can occur, but it's pretty uncommon. Then Omicron came along, as we're all aware, and so we've been able to look at some of the US data and try and understand the severity of illness in children with Omicron compared to Delta. And on an individual basis, it is much less severe. So kids are 70 to 80% less likely to need to go to the ED and about half as likely to need hospital admission with the Omicron variant. Long COVID is another thing that we're asked about constantly with children. There's been so much conflicting data around this, mostly because the studies that were conducted were just quite poor. They didn't have control groups. They completely overinflated long COVID. So we're now starting to be able to see some really good controlled studies where you were able to compare kids who test positive for COVID and those who don't test positive to COVID but had a respiratory infection, and then follow them forward. And what they found is that less than 1% of kids in general have symptoms that last for more than 4 weeks. And there's a really good systematic review from Benoud there. You can see that reference that really shows this very nicely in terms of, from the controlled studies, just how uncommon long COVID is compared to adults, where, you know, up to 30% of adults can have chronic and persisting symptoms. And I think it's much more of a problem. And then it's important to also just consider this rare post-inflammatory syndrome called MIS-C, or multi-system inflammatory syndrome in kids. I'm sure you're all aware of this. It occurs about 2 to 4 weeks after the initial infection. It's pretty serious. All kids need admission to hospital. A small majority need admission, well, actually more than a small majority, about half need admission to ICU. And it occurs in about 1 in 3,000 children. And the vaccine offers very good protection, over 90% protection after 2 doses against this syndrome. So then when we are talking to parents and we're saying, right, you know, should you vaccinate your primary school age child? Of course, we go through all of those direct benefits in terms of preventing disease, talking about mild illness, but the pointy end of severe disease with hospitalisation or ICU admission, the PIMS-TS or MIS-C, and then long COVID, which we believe is quite uncommon, but just to highlight that there's a lot more research going on with consistent definitions to try and get some better data. And then, of course, unlike other vaccine programs, we also need to consider the indirect benefits. And, you know, that the vaccine does help to reduce transmission from children in the household, in the community, and in schools. And of course, if kids are vaccinated and they are less likely to get infected themselves, then of course, if more children are vaccinated in the school setting, we can try and, with all the other measures, reduce cases and outbreaks in schools and therefore maximise face-to-face learning. But this is also a tricky message because it's actually not just about vaccines in schools. We need multi-layered strategies in schools. Vaccines are just one part. And in fact, you could argue that booster doses for teachers is the most important part of the vaccine program in schools. And that obviously primary school kids getting vaccinated is important, but so is improving ventilation, wearing masks, and all of the other strategies that, you know, we're trying to institute in the school setting. And that's another area of work that I've been working closely with the Victorian Government and the Department of Education on a plan for schools and how to prepare schools and actually how to implement this in the school setting, because you would have all seen Brett Sutton announce the 3V, Minister Merlino and Brett Sutton talk about the 3Vs program, which is vaccination, ventilation, and vital COVID safe steps. And when they talk about ventilation, Victoria actually purchased 51,000 air purification filters or HEPA filters. But, you know, in term 4 last year, they were not installed in a timely way. And we've seen this in New South Wales as well. So there's been a real push in the last 3 or 4 weeks to actually try and institute change in terms of ventilation in schools, install the air purifiers, build shade cloths. I think there's 1,800 schools in Victoria that have got grants from the Department of Education to build shade cloths so that kids can learn outside, and about 300 schools are already doing that. So really important that we frame vaccination and these indirect benefits in terms of schools as part of a suite of strategies and not just vaccination. So very quickly, you know, with Pfizer for the 5 to 11s, the trial that was published in the New England Journal of Medicine was a pretty small trial. It was only in over 2,000 kids. It did show really high efficacy data, over 91% protection against symptomatic disease. But the trial was just too small to give us any information on protection against hospitalisation, and we had no information on serious adverse events such as myocarditis, which is why Australia chose to wait another 4 to 6 weeks before the TGA approved it here. Started their rollout in the start of November. Just went with this trial data and rolled out the program. We waited 6 weeks until we were reassured by real world data that the risk of myocarditis was low in this age group, and then the TGA made a recommendation and ATAGI approved it. Questions about kids and the vaccine, and, you know, if they are 11 and just about to turn 12, should they get the higher dose or the lower dose? We know that it's 1/3 the adult dose, 10 micrograms. It's an 8-week interval, but it has been shortened to 3 weeks for kids who are at higher risk. And at the moment, if kids have had COVID infection, as many have in the last few weeks with Omicron, the latest advice is really just to get vaccinated as soon as the child is well. You could wait 3 to 4 weeks, but in general, with the sort of pressure of Omicron, I think it is really to go ahead with vaccination if the child is well. So I'll skip over this and just tell you what's been happening in the US. So now, given that they started their program, about 9 million children and nearly 5 have been given a second dose. And this is really important because, as we know, myocarditis happens more commonly after the second dose of 5 weeks. So see this dose 2 data to be able to understand the myocarditis risk. And important to know that there are only 2.3 million primary school age children in the whole of Australia. So, you know, US are well ahead of us, and we can really learn from their experience and these real world data. So in terms of vaccine safety, you know, the common and expected side effects by far and away and fatigue. So really is about 1/10 of that, what we've seen in teenagers. And here are the numbers up here. Boys, dose 2, you can see the highest risk is in 16 to 17-year-old boys, 70 cases of myocarditis per million doses of vaccine. And in the primary kids, it's 4 cases of myocarditis per million doses of vaccine. And it's about 45 in the 12 to 15-year-olds. So this is a good news story. This is something we need to be sharing with parents, explaining the lower risk, because this is the main risk, if you like, associated with the vaccine that parents are sort of weighing up their decision against. And this is really the other take-home message, is that, of course, you know, myocarditis, the risk of myocarditis from COVID infection is about 7 times higher than the vaccine. Now, I might skip over this. This is just a personal passion of mine and something that I've worked in clinically for many years and do a lot of research in trying to manage needle phobia or needle distress in kids, both in neurotypical kids and those with developmental disability. I co-host a podcast at the Royal Children's Hospital with 2 other paediatricians, and we've just recorded one on needle distress or needle phobia, which has been really heavily downloaded and listened to. So we know this is a big issue in the community. And when I was working with the department last year, put a lot of effort into creating the pathways for children to provide the optimal support for them. And we developed this plan for parents, which is online, on the sorts of things that they can go through to plan where their child may be best vaccinated, whether it's with a GP, whether it's at a pharmacy, or whether it's at one of the hubs. And in Victoria, the 18 hubs have been really equipped with a lot of distraction materials and collateral. So there's, fidget spinners, colouring books, and there's the Cool Sense wands, the Buzzy Bee, and the virtual reality goggles. So not every general practice can possibly have all of that distraction equipment, although many may do. You may offer that in your practices, but not all GPs can do that. So for kids who do have more needle distress or phobia, or kids with autism who need a low sensory pathway, we've tried to really create that. And then, of course, the next level up from all of that is there are 6 hospitals in Victoria that offer awake sedation for kids who need midazolam or nitrous oxide, and we've got a pathway for that. We also in Victoria worked very hard on supporting kids with disability. So there are these fabulous disability liaison officers who are on the end of the phone to work with parents, advise parents on what that child might need in terms of support, and they can even arrange vaccination at home. I might skip through this. This is my other passion and research interest is around effective vaccine communication and trying to understand where the person you're speaking to or where the parent sits on the vaccine acceptance spectrum. And this is really the kind of communication approach, I suppose, that I've developed over nearly 20 years of working in this space. And, I'm not going to teach you how to suck eggs. GPs do this so well and so beautifully. But this is what we often get asked about, of how best do you communicate? How can you approach a conversation with a vaccine hesitant person or a refuser? And I can run through this a bit later if you like. I won't go through it all now because I don't want to talk for too long. But also talking with kids really is another area that we're getting a lot of questions about, in terms of really giving the child an opportunity to ask questions, express their concerns, and talk to them honestly about the experience of having a vaccination. Because a lot of primary kids, if they don't have the flu vaccine, their last vaccine is when they were 4 and the next one is when they get to year 7. So it isn't actually a common thing for a lot of kids, kids in this age group, to have needles. And then I did something for Melbourne University last year called VaxFacts, where I recorded in the end, I think it was about 35 videos answering common questions about the vaccines across the program. And this was really nicely received because some people like to consume information by watching it. And they're sort of short, 1.5, 2-minute videos where I just talk about the answers to common questions and we try and link to information. And, there's fantastic information out there for people with disability, decision aids, multilingual glossaries, easy read information. I'm just not sure how well we get this information out there and how accessible it is to everyone. But this really goes a long way to answering people's questions. So I'll stop there. I'm sorry if that was a bit long, Magda.
Oh, that was excellent, Margie. That answered a lot of my own questions. So thank you so much. That slide that you just, the last one with all the podcasts,
yes.
I think that they are really valuable, and had I had something like that available to me, that would have made life a lot easier too. So if we could have access to those, it's UniMelb. I have actually seen them on the UniMelb website and didn't click on them, of course, because you sort of reach saturation point at some point.
Everyone does, absolutely. And that's what I mean. I think there are so many fabulous resources out there and it's quite hard to share them. And and get them out there. But those short videos on the VaxFax Melbourne Uni website, I can put a link in the chat. And the podcasting that we do through the hospital, we've just done one on return to school, where we've gone through a lot of these complex issues around return to school, because there's been a huge amount of anxiety about that. So I can pop that in the chat as well, if that's helpful.
Great. And then we can have that up on our website, because we do have a dedicated site on our website on COVID-19 with the latest.
Oh, perfect.
We've been
Maggie, what we do is we're running a vaccination clinic for children in a country town that I live in and work in. And I've put the people in our country town, the parents are very well educated, and they've also got a COVID site of their own. And I put a link to your podcast.
Great.
Especially on things like needle phobia, which we actually haven't come across a lot. We chose one of our doctors that everyone likes, which therefore wasn't me. And they and that particular doctor is great fun, a good comedian, and he's been wonderful with the vaccination clinic for kids.
Yeah, fantastic. And I agree.
Your podcast.
Oh, good. I mean, needle phobia, you're absolutely spot on, Marjorie. It is about the approach. And, you know, at the Children's Hospital, we have these extraordinary nurses who've been doing it for so long, who are just brilliant with kids, and they can really manage it without needing to escalate to a lot of that higher level support I was talking about. So the approach is everything, and making the child feel relaxed and calm and in control. It's actually a really lovely space to work in, because you have these terrified kids that you can actually step through, and by the end of it, because we want them to have a positive experience, they're going to need at least one more dose and then many more vaccines in their life. So this whole concept of just get it done, hold them down, 6 people pinning kids down, that really doesn't happen anymore. Well, I hope it doesn't.
Well, that was how I was vaccinated at school.
Margie, your programs replicated in other states, do you know? Because I think Queensland is a bit lacking, I'm not sure, but we have had an autistic child who, you know, the mother was beside herself trying to get him vaccinated. So
yeah. Well, Lydia, the autistic children who are non-verbal and have a lot of behavioural difficulties, that's probably the most common child that we would see in the hospital setting for awake sedation. A lot of those kids will either have just nitrous oxide, and some of them we're now trying to do it with the virtual reality headsets, but some of them hate anything on their head. But some of those kids are the ones that do need the oral medication, the midazolam, wait half an hour, and then the nitrous oxide. But having said that, another proportion we can manage beautifully in the low sensory environments, low light, low noise, nice distraction, calming. They don't need any of that. So it really depends how challenging the child's behaviour is.
And she said she consulted the Children's Hospital, the paediatrician, the vaccine, you know, health department hubs, etc. So very difficult.
I think we have a number of paediatricians here and nurse immunisers in Victoria who are very, very passionate about this. And so a huge amount of work has gone into setting up these sorts of clinics and these pathways here. I had a PhD student who's just finished and has done amazing work in this space. So I think we probably have a skewed view down here, because I don't know exactly what happens in other states, but certainly I do feel that we have a lot of pathway support here for kids with needle phobia.
Well, thank you for those resources, and I'll put the mother onto them.
Yeah, thanks, Lydia. I'll put these.
Charlotte, we've got the similar things in New South Wales. I'm on a violent group with one of Sydney's paediatricians, and they've had a lot of experience with that in Western Sydney.
Yeah, Nick Wood, I think, mainly has run that clinic. And you're absolutely right. The New South Wales guys do a lot.
Well, thank you, Margie. That's been really, really helpful and informative. Thank you so much. Charlotte, your presentation and your chat now about your experiences in New South Wales. So if you could just give us a bit of an introduction of your role in your state also and what you've been doing.
Thanks, Magda, and thanks so much for the invitation. I'd also like to acknowledge the traditional owners of the land that we're all on, but I'm on the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present, and upcoming. Thank you, as I said, for the invitation. So for those of you who don't know me, my name's Charlotte Hespy. I'm a GP. I'm based in the inner west of Sydney, and I like all GPs, and probably everybody in the room here, juggle a number of different roles in that. And one of those roles happens to be that I'm the current chair for the New South Wales ACT faculty for the Royal Australian College of GPs. And again, if you don't know, the way that the structure of the Royal Australian College of GPs works is that if you happen to get that role for being chair of your faculty, that means that you actually automatically become a director of the board for the national organisation. So you get a director role as well as actually overseeing the faculty activities. So it's double whammy joy, really. And so that's sort of been where I've been sitting. So with the, it's sort of quite interesting because when COVID came about, as sort of in my role for New South Wales ACT, we were amidst disaster management for bushfires. So if you weren't in New South Wales or ACT, you may not remember, but we had these quite horrific fires all the way down, particularly the south coast of New South Wales. And it was just, I've never known it be so bad. There was just smoke everywhere, and there was lots of asthma. There was lots of loss of homes. It was all sort of particularly really came over that sort of period post-Christmas and into the new year. So I actually sort of set up a disaster management group that was particularly focused on being where the bushfires were. But as part of that committee, what we were trying to do was reach out to the GPs in that area, find out exactly what they needed, what was going on, and then use them as the portal of being able to both tell us what was going on and then feed out the resources. And I used my role with the relationship I had with New South Wales Health to try and facilitate better access to the things that were needed and with the PHNs. And that actually worked really well. We also reached out to all the practice managers and really sort of got a real hands-on understanding of what was going on and what was needed for the communities as they were facing the disaster. And can I say one of the biggest things, and this happens every single time, was the big complaint about the fact that GPs were overseen in all of the disaster responses at a sort of a state level, because the dislocated funding that we have with where primary care sits by being funded nationally, we sort of miss out on the states really getting the value of involving GPs. So an outcome of that was that as the COVID came about, I have a very good relationship. I'm really fortunate with the Chief Health Officer in New South Wales, Kerry Chant. And so sort of, you know, with everything, was very quickly aware that this was going to be a really big deal. And so set up a meeting with as many people as I could who I knew were GP leaders in some way or t'other across New South Wales ACT. And it was really fascinating. It was a series of meetings that I organised. They were all last minute, but I had pretty much 100% attendance. And so we're talking, one of the first meetings I had got 80 GP leaders from across New South Wales ACT, and they all attended to that at that meeting. And we were able to really quickly see that everybody really wanted to have a means of better communicating and being able to respond. And so we set up a virtual community of practice that was established on a platform called Basecamp, which is a platform I hadn't ever used before. And it's quite different from Facebook and Twitter and things like that. It's not a social media portal. It's very much communication data management. And it's been absolutely fabulous because we do messaging, emailing, we can put up information, share things. But what it's done is it's really, and you can then set up your own little communities under it. What it facilitated was this incredibly reactive, but very well networked GP leader platform and across the state. So we tried very hard not to reinvent wheels about how we were responding to things, but we were also really very quickly able to get the feel for what was happening at the coalface, where the issues were the gaps in communication, what assistance we needed. I was then able to feed that up into New South Wales Health through the wonderful assistance of Kerry Chan. And we were able to then get GPs into key places. One of those, really importantly for us, is a thing called Health Pathways, which I think is now national, but really New South Wales has, I think, rolled it out the most efficiently. So every single local health district and PHN has an active health pathways. And what health pathways is, if you don't know about health pathways, is it actually documents pathways of care for conditions, but more importantly, regionalises where as a GP we have to interact. So for instance, we're going COVID. When I'm looking at how I'm caring for COVID in the community currently, which is the biggest deal for the GPs in New South Wales, you actually go on there and can find exactly what the clinic is, what the phone number that you've got to be able to ring the doctors locally, so you can actually fast track patients to MABs, for instance, or be able to get them into hospital, understand whether we actually can get a social care package for them, and sort of help with that facilitating of information. And it's been really amazing. So we've got uniform sort of pathways, but they're different in every single hospital, local health district, just because of the joys of the way in which New South Wales works. I'm sure other states are similar, but it's very frustrating as a GP because you can't just say this is how we do it, because it just varies everywhere. So these health pathways are really good at helping us navigate some of the changes that's doing that. At the same time, we set up a series of webinars where we, again with Kerry, basically made sure that we invited the people that we thought were of the topics that were particularly interesting or, needing to be upskilled on at the time. So, for instance, Margie, with vaccinations, we've been really fantastic. We've had a lot of the time, we've had Christine McCartney, who was chair of ATAGI, who at that time, and she was able to come on, present actually what the information was, what the evidence behind the decision making, and help GPs sort of understand what the recommendations were and what they were. Kerry does updates on what's actually happening with the data and why decisions are being made, take sort of any sort of questions, and it's been a really, really, I think it's hard because I'm sitting obviously as a sort of facilitator of those, but the feedback I get is how useful they are. And I think, there have been times when we've had over 2,000 potential attendees, but we can only unfortunately host 1,000 at any one time. So what tends to happen is we'll often max out on participants, but then it will get uploaded because we record it afterwards. And the number of uploads, I think there was one time when there was 5,000 uploads of a particular webinar, which I think is a really good indicator of that we were meeting a need for the GPs at that time in terms of information, because it was just this constant change, and so sometimes the webinars were weekly, but we sort of got to a lazy phase of when we were sort of doing them 4 to 6 weekly, and of course we're now back in a more rapid phase again, and again we sort of did them just weekly with this Omicron, and now we're back to fortnightly again. We also extended the number of people we invited on and the length of time, because we had so many issues around immunisations, boosters, children's vaccination. How did we manage COVID in the community? And, what was the risk matrices that you had to, how do we juggle safe staff, patients, telehealth, all of those sorts of issues at the time. Is this sort of meeting the mark in terms of what you were interested in?
Absolutely, Charlotte. I mean, I'm listening to you and part of me is drooling because what you've described about the method that you have used in New South Wales has actually been like a light bulb in terms of explaining the disparity between the New South Wales response and the Victorian response, and why whenever we had accidents occur with our, let's say, quarantine, and with, we had 2 individuals who, stuffed up the quarantine, as the quarantine was stuffed up, and we had an enormous issue here tracing COVID and COVID carriers, and we then had to go into lockdown, and we've had to go into lockdown, and one of the explanations that we've been given is that, geographically the 2 states are very different, and that the demographics are very different, and cultural groups, don't mingle as much, but the reality is that we're not that dissimilar in that respect. What is vastly dissimilar is the process that you've described here. So, for instance, health pathways, as a GP, I mean, this is actually really primary care material, but with respect to what Charlotte has described, this is like one of those great ideas about getting GPs and getting the primary care sector all unified so that we're not all working in silos out there in the community, and so that we can interact, especially when there are sort of uniform and issues like this that need to be responded to quickly, and also just for the ease of accessing services and directing patients to the services that they need out in the community and so forth.
It's the sharing of ideas too, Magda. Don't reinvent wheels. Well, don't waste time. I mean, when I first started doing it, I could see what was happening was that there was about 30 different GPs all doing exactly the same thing because they all could see what they needed to do. And it's like, hey, guys, let's just share it. Don't all just do it. Let's improve on it by getting everybody's brain working on the one system. And so there's been a lot more of that. With the health pathways, can I say that it's also really good because although the GPs write the health pathways, they actually have to talk to the specialty teams in terms of actually developing it. So what it actually means is the relationship between the specialists and the GPs is really improved because both sides get to understand where you're coming from. So you actually end up with a much better solution about how you access and write things and communicate things, because we're all in the same room together, and all of a sudden it isn't about him and her, it's about us. How are we actually going to make sure these services get delivered for our patients in the best possible way? And, so it turns it better into patient-centred care. We're very good at talking about patient-centred care when it's really continues to always be clinician-centred and service-centred. And I think some of the health pathways work helps to sometimes bring that out and about. But yes, I think we can all learn from each other, can't we? I just love.
But we don't use health pathways here. Yep. So that's the big difference. So I think the uptake here in Victoria, I think 2-3 years ago was in the order of around 6%, but now I think it may be in the order of around 12%. So when you say that you had 100% attendance at your meetings, that's not the case here. So it's been a lot more difficult to coordinate things here and get everybody on the same page and get all the PHNs and get all of that interaction.
And I think that was part of that sort of foundation work that I did when I first invited people, because it was from across the board. It was the PHN leaders, the clinical council leaders, the AMA people, it was the college people, it was the ACRM people, it was the rural people. It wasn't, I'm totally, I don't really care who you prefer to get your information from. I don't really care who you align with. I care that we're all doing the same job and we're doing it. We need to do it together and we collaborate. And so it's been very much about collaboration. And so again, I've got a really good relationship with AMA, and we're doing all of that sort of work together. Currently the chair in New South Wales is a GP, fabulous woman leader, Danielle McMullen, and that's been, again, really, really fantastic. But we've got good relationships across the board that we're trying to, continuing to build, and that's key. Communicate. I'm such a strong believer in that, and being respectful that we've all got a really important role to play. Can I tell you, we're still battling with a huge number of stuff that's exactly the same as all other states. But I think I've had more headway in the getting of the role of GPs through this pandemic than we've ever had. So, for instance, I was at a meeting today which is around the COVID care in the community, and I mean, I was banging on about the fact that until GPs are actually told about every single positive COVID case in the community, they won't and they cannot make use of the value that we have in understanding our patients and being able to identify who is actually the high-risk patients and need to then be accelerated up. And there's a lot of wasted time in having to try and find them when they don't actually use, a source of information that's really helpful. And at the moment, I mean, I don't know what it's like anywhere else, but we don't get communicated with at all about COVID cases. And it's very interesting because they've funded Health Direct to do that. And yet so far Health Direct is apparently completely unable to do that. So although they've funded them to do it, I mean, we're now coming up for 2 years in, they've funded them for I don't know how long to do this job, and we still haven't got a bean on the table. So I'm just there going, I don't really care who, it's too political who's paying for it, just do it. We're talking about all of these barriers around how do we identify these high-risk patients. Well, the first start is just make sure that we've got a GP identified and let the GPs help you, because we can.
Yeah. Well, that's impressive, Charlotte. So that's I think we'll have to sit down and talk more around what that strategy looks like on a whiteboard or on a sheet of paper and replicate it. I think that's a story you need to share with the rest of the states. Like you said, no point reinventing the wheel.
Yeah, no point in reinventing the wheel, but you do have to do it from a foundational thing. It's sort of it's that relationship thing that's the really important thing, and building those up. And, really, and moving forward is being able to build on those and understand the value we each bring to it, and try not to be precious about, it's very easy to be just seeing the viewpoint of who we are and what we can bring into that. Sorry, Marjorie, you were going to talk.
Oh no, I was just going to say that the national news used to show Daniel Andrews and Brett Sutton, but our amazing news was always fronted by Charlotte and Kerry Chant. So those two were always there in the New South Wales news. But there are a couple of issues, Charlotte, and yes, Health Pathways is superb, and I've written some of the Health Pathways in ACT and Southeast area, but our border issues are really interesting. The jurisdictions across Queensland, New South Wales border, Victoria, New South Wales border, and ACT, New South Wales border, because we have those different jurisdictions, there have been some problems. And Charlotte's chuckling now, but they really are the ornery parts of the system, because in my area, any sick people will have to go to the ACT and be transported by a New South Wales ambulance. And so
Broken Hill, Marjorie, also is another bit, because their actual pathway is actually to Adelaide. And of course, with COVID, that was completely shut down. And so poor Broken Hill patients who had no relationship with any other health services except for what was in South Australia had to totally build new referral pathways and access of care, etc. So, yeah.
That was certainly much more problematic. But what I was getting at is one of the learnings that might come out of this issue is this federal-state divide in health. Almost have to think about it's not going to happen quickly or easily, but we almost have to think of a different way to provide these services where they are not based on these smaller jurisdictions. What do you think about that, Charlotte?
Oh, look, you know, I mean, I'd love to just break down the silos and get the whole stuff about, you know, funding and things. Because can I tell you, I really don't think we're going to solve a whole lot of the primary care versus hospital community care funding until we actually all have the same funding source, you know. Because I hate the thing that we're fighting for funds one way or another. We shouldn't be fighting for funds. We should be actually understanding where's the best value, and we should be being judged on delivering value to the community that we're serving.
That's all really important. Yeah. That's really, really important. Yeah, I mean, you know, that's the crux of it, isn't it? I suppose it's time now for me to share some points here on this topic also. I'll skip through mine very rapidly because I think that, you know, what we've talked about tonight has been really interesting and has covered a lot of the really important things. And I don't think I've got all that much to add other than the sort of issues that GPs are facing, which I think from the perspective of dealing with this whole pandemic, it is about where the GP sits in this discussion and how we've been treated and how we perceive we've been treated. And yet that, and by government and by the systems that are providing a lot of the recommendations, but also about how the community view us and how they need us to be in a position of confidence and also well-being to be able to manage all the uncertainty that's out there. So at the moment, what we're facing, and when Omicron came and swept through our states, the eastern states, you know, it was about accessing RATs and PHNs with all that we've been talking about, you know, the primary healthcare networks, which we rely on for delivering our supplies of PPE and sadly also RATs, has been very poorly distributed. Our communication isn't all that great, depends which PHN you're in. Then there are the questions about, you know, how do you really know whether or not your patient is truly vaccinated? And there's been no way of really knowing whether or not our patients are vaccinated and whether or not their symptoms are COVID-19 related or not. Because, of course, you know, we had the national message broadcast, if you're feeling unwell, go see your GP yet again. So we were facing these situations daily, facing these confusing messages. And RATs are not all that they're, you know, outlined to be. There are, you know, ways of interpreting what the RAT really represents. And of course, it depends on your pre-test probability, which means your state of health and what your symptoms are and what your clinical presentation is, their sensitivity and their specificity. And it also depends very much on which stage of the disease a person is RAT tested in. So saying I've had a RAT and I'm negative, can I come and see you because I'm still feeling crook, doesn't necessarily mean that they're not positive. And we've had, you know, a paucity of PPE in our rooms. So, you know, GPs have been dealing with a heck of a lot of insecurity around our own safety and what that means. And until we knew more about Omicron, you know, was it the same as Delta? It's not the same as Delta. It's not as severe as Delta, but of course it doesn't, we don't really know because there's not that much genomic sequencing. So we're learning to live with COVID. It soon will be endemic, but does that mean that we can give up on this and just take it easy? Well, certainly it's not harmless, and we know that we can't relax just yet. So, of course, this is just skipping through RATs and understanding them, which I won't go through. And, of course, we've been told to test. And, of course, we haven't been able to access tests. And not even for ourselves, not even for our staff. So we've entered the Omicron wave, face-to-face, telehealth. Most of us, I have not stopped conducting face-to-face consultations except for the very first phase of the COVID pandemic. And, you know, you have to hedge your bet every single time you see someone. So masks, ventilation, social distancing, hand washing, cleaning services remain really the best way of protecting yourself and protecting your staff. And I've just got here, of course, the BMJ COVID-19 test calculator, which was published in 2020, but of course it's still really valid because they've been updating it with respect to the rats. Now, when we're talking about this is, you know, these are the complex sort of grey areas that we're dealing with in day-to-day practice. And we are, you know, we're literate, we're health literate. And then, you know, we make assumptions about the way we communicate things and all the different language barriers that really exist. And health literacy in the community, this has been a huge issue throughout the entire pandemic. So we could be doing all the right things, we can be having all the right discussions, we could even have everything else lined up really well. But unless we're communicating well with our diverse communities, there's going to be an enormous sort of mismatch between what we're intending to achieve and what we're seeing. And of course, I'm not sure if you've ever tried the coronavirus helpline. If you've rung in general practice, it's a nightmare. During the pandemic, they'd literally, this is a doctors trying to find out and get advice on how to tracing patients or finding out results or how to manage them or what to do in your own practice if you suspected someone was positive or someone rang and said that they'd been positive, what you actually had to do. So and then of course accessing information in the diverse languages has those websites that the government has in find information in your language. Well, if you click on those translations, they're not really up to scratch. And so what we've known is that the government's websites haven't been communicating really effectively with CAL groups, and a lot of the CAL groups have been really hesitant to be vaccinated, and especially hesitant to vaccinate their children. And even hesitant to have tests because, you know, they know that if they test positive, then if they're casualised workers, they will not be able to go to work and they won't be paid for not working, and it means that their entire family suffers. And unfortunately, when people are in doubt and they're scared, they do go onto the internet and they get lots of misinformation. However, and also the media, I mean, it's really difficult to understand and interpret what's going on out there. But this study indicates that doctors have actually become the most trusted of all the professionals in the community, and this is internationally. In Australia, I believe that it's probably right up there for GPs. However, you know, GPs are strained. We're under a lot of pressure. It's been difficult to make it financially viable to run vaccination clinics. I have some very dear friends whom I have an enormous amount of respect for professionally who decided not to run vaccination clinics in their practices because it just wasn't financially viable. And they're just, you know, they've been doing telehealth, charging what they normally would, and doing, you know, the sort of the other sort of mainstream medicine, and but not doing any vaccinations. And we've had all the difficulties of, you know, repeated changes to vaccine eligibility and the embarrassing situation where you have patients informing you of the latest changes or arguing with you over guidelines and recommendations. So as a consequence of a lot of this insecurity and shift, they've been that GPs as a whole have been struggling to maintain their mental health. Statistics indicate that it's probably been one of the ugliest and most difficult times in primary care, and yet we're the most needed in so many ways, and we're providing that sort of break, this sort of stopgap between the primary care and the tertiary system being overwhelmed. And I mean, I'll click through all of this, but this is, I mean, I was talking here about self-care and what it really means. I think that that's really important. I don't know that we've had enough training in this. I've been talking a lot about this extensively, and I'm going to skirt through this because it's not the sort of stuff that we don't know, but and because we're racing through to finish and take you all to the end of this conversation so that we actually can interact a bit. And this is part of a presentation that I've given several times, and through this I also deliver a few little exercises on how to retrain your breathing and how to bring that sort of stress level down in the middle of the day when you're dealing with a lot of this anxiety in the community. And of course, accessing supports for ourselves and being conscious that this is something that is out there, and also that doing it. You know, I think during this period I've probably seen more health professionals as patients than I have ever done before, and that's a really telling sign that this has been really difficult for a lot of us out there, and more of the resources. And just a quick thank you. So I just wanted to run through this and talk briefly about health literacy and accessing community. And I think one of the things that you did here, Margie, was you conveyed all those really important messages in those podcasts and in the YouTube videos for professionals to use, which has been fantastic. Having those shared is another thing. So how we share our information and how we access this information, to think that this wealth of information was out there and, you know, people like myself haven't used it, is one of the things we probably need to look at addressing. And likewise, I think one of the things that I've tried to do in a variety of different ways throughout this phase is communicate with community through direct messaging, through using media, and through our own CALD community, specifically the Greek one, but also framing those strategies in a way that other GPs can use it within their own communities. So, for instance, the Asian communities and the Vietnamese and so forth. So giving directions on how that can also be replicated. And I think that one of the things that more recently demonstrates how important it is for us to step out of our consultation rooms. So we're doing a lot of that in terms of, speaking to government and talking at a lot of the health reform discussion tables. And I think that it's also really important that we come out of our environments and also make our information more public and more accessible to the general population. And one of the things that we're all doing, is we're doing that one-on-one through our patients. But I think that, I sort of got very frustrated when I was telling the same story over and over and over again with the recent COVID explosion to patients who were at home unwell. And I thought, well, which is what led me to writing the article for The Age. And when I emailed the editor and the health editor, and I asked her if I could do that, she sort of said, well, she hesitated and said, we don't usually print health information. This is not what we do. But I see your point. Let me speak to the editor about this. And then the editor came back and said, yeah, that's a really good idea. And I sort of submitted the article to them so they could have a read to it, and they recommended that the health department have a look at it and give it the green light, which they did. And the health department came back to the editor and said, well, actually, yes, this is a really good idea because she's doing our job for us. But I think that that just indicates how difficult it is for the health department to get people to hear what they need to hear also. And maybe that's also something, Charlotte and Margie, you can also bring to those discussion tables when you're there, about how the message to the community is delivered, and also repeatedly too, in that calm way. Because I think that there's been a heck of a lot of fear-mongering out there, and that's through the media. That's not through us. We're the ones that reason with our patients, and we have the dialogue, and we have that sort of confident air about us when we're talking about, how to manage disease and how disease can change and progress and be different at different stages and the different symptoms. So we can explain that to people, but the fear-mongering that is out there has really taken its toll, I think, on people, which created that barrier for GPs in terms of getting the vaccination message across and getting people back in. And we also experienced the dramatic number of patients drop off from our vaccination lists. Whenever there was an announcement made on the television, all our vaccination bookings were cancelled. Like, you know, we had maybe 30% of our patients turn up and we had vaccines that we had to throw out. So these are the sorts of things that maybe having doctors out there in the media space delivering these messages, I think, is really important. And not just Norman Swan, on you know, who does an excellent job in his own way, but I do think that maybe in the more mainstream ways that might be something for us to really think about too. So that's, any thoughts, any?
Yeah, no, Magda, I would agree with that. I mean, we did that webinar together for the Greek community last year. And I think in total, working with the department, I think I was involved in 60 of those webinars with different cultural groups, high-risk groups, homeless people, people with disability, providers, industry. People really want an opportunity, as you're saying, and I think, Charlotte, you highlighted this as well in the forums that you were running. People want an opportunity to hear the information, digest it, and ask questions. And, you know, one benefit, I think, of the pandemic has been this transition to these sorts of Zoom meetings so that people can attend more easily and share information. But I think they need an opportunity to ask questions, hear other people's questions, and that sort of real, it's kind of online community engagement. It's totally opened my eyes in terms of how best to answer people's questions and concerns and address hesitancy. And as you said, Magda, there's just been so much misinformation shared that to cut through, that's what you need really to build trust, and to, because it's all about trust. People are not going to listen to a word you say unless they trust you, and they won't hear the message. So yeah, it's really interesting what you're saying about the different communities, and health literacy is absolutely critical. So much of the information that is put out by government and the messaging is just not cutting through. That it's not reaching people, it's too dense, it's not written in a way that they can digest it. They're not stupid by any means, but the information is not appropriate. So I think we've learned a lot in terms of how to communicate and how to communicate well.
Can I say, I think we still need to do better, but I agree with you 100%. Can I add to that? I actually think that it opened my eyes up to how much we have to upskill our own professional teams on health literacy too. And you know, this was new territory, there was new stuff, and so everyone's been upskilling constantly, and we need to be able to take them with us as we do that learning journey. And that's been really a wonderful opportunity too in terms of doing it. But you know, like for me, sometimes think, oh wow, I really have to go over this again and again and again and again in order for it to make sense to people.
Can I say two things? One's a question to Magda and Margie. Magda, you said that you don't know whether people are immunised. As a vaccinator and having vaccination clinics, we have to put it up on the Australian Immunisation Register. Can't you check that people are vaccinated? No, you can go if they've got an active...
No, it's being rolled out this week. You can.
Yes, I know, but this is a bit late though, Charlotte, isn't it?
But you could do it before as well. You could go onto the Australian Immunisation Register. It just took a long time.
It took ages. And
you can do it through this electronic My Health record.
But not everyone has got that activated. So some have opted out. So that's the other thing. So if you didn't have, if they didn't grant you access. So even if they did, if you didn't have access, you couldn't see that. So
my reception staff do it at the reception desk.
Well, ours don't, and I think it's a huge amount of administration work. And as Charlotte said, it does actually take a long while. So now the immunisation that it's not the AIR, it's not the Australian Immunisation Register, it's the vaccination information. It's just been activated this week because they were talking about that, rolling that out only, throughout this whole period, because that's been a huge issue for GPs. So we haven't been out.
There's also a search that's just been added, which is something that I did a lot of jumping up and down to do, was to be able to say, as a practice, we can now do a mass search, so we can find out our practice data. So we've been, at the moment, we individually search our whole practice database constantly to know who's been vaccinated outside of the practice as well as inside, so that we could actually target all of the unvaccinated. And it's been a big project. And so out of that, it was just like, oh, surely there's an easier way of being able to do this as a big dump rather than individual every single patient. And so that's been activated this week too, Magda. So you can actually start to do bigger practice community searches, so we've got a better understanding of, who's needing boosters, et cetera, et cetera.
We just started that. And the other thing is when you're talking about getting the information out to the practices, at least where you've got a website and a Facebook page, you can actually put all your work. And I put Magda's article and that podcast of Margie's onto our website, so that patients' families can actually access it through our website.
That's a really good idea. I suggested that at our practice. They still haven't activated that.
Yeah, you have to have someone that does it.
That's right. Yeah.
You actually have to have a person that does it.
Yeah. Any questions from anybody else? No, I think it's 9:12. We've been here for, an hour and a bit, and I think it's been fabulous. Hi, Desiree. Hi, Gay. Yeah. Margie, thank you so much. Charlotte, thank you so much for your time. Thank you for your wealth of information and for what you've been doing out there in the community to keep our young people healthy and our communities healthy, and also for supporting GPs and getting the primary care profession up there in terms of the mind of government and the health department, because this has been probably the most spotlight we've ever had, and hopefully with that there'll be some positive outcomes to Charlotte in terms of the way funding is delivered to primary care and the attention that it's given, and the support that we're also given to actually continue doing the work that we do. So I want to thank you all for coming today. This will be uploaded onto our website. We have also an AFMW YouTube station, and we'll have it up there too, and you can share the link with whomever you like and on your social media. And I'd just like to thank you all again for tonight.
Can I thank you, Magda, for your role too, and for the really powerful role that you've had in communicating so well about how to help the vulnerable parts of our community in particular understand what they needed to do. Thank you. I'm very well aware of the power of your work. Thank you.
Yeah, I agree, Magda. And to, honestly, all GPs, I just really honestly want to give a huge thank you to all GPs and the work they've done. I'm not sure how they haven't all reached burnout already. So I hope, they're an incredible workforce.
Thanks a lot, Margie.
Well, our local hero in New South Wales is Charlotte. So thank you, Charlotte.
Yes. Good on you.
Thank you to you all.
Thanks a lot, everyone. Good night.
Take care, everyone.
See you.
Bye.
Bye. Bye.